We're at the top of the hour, so it's Friday, May 9th, and joining us today on the Florida NEMSP webinar on his birthday is friend of the show, Lew Steinberg. He's going to be talking to us today about quality management in EMS, touching on some different things, difference between quality assurance, quality improvement, and illustrating all of this with real world examples. So, Lew, floor is yours.
Okay, thank you. So just quick background, because I don't talk much about myself, but I started as an EMT in 1971, was a fire chief, firefighter paramedic, ran a patient simulation center for College of Medicine, and I'm still involved in paramedic training for a few of the fire departments. So enough about me. Here's what I picked up along the way. So QA. QA is usually what's going on in most places. It starts with report review. So we're looking at reports, so they're thorough and reflective of the situation. I always read it with an eye in mind, which number two should place a lot of people on here. Can the medical director pick up the report and put himself at the scene or herself? Can they picture exactly what you were facing so they understand why you did what you did? The next thing has gotten to be a major issue. Is it clear and well written? Grammar and spelling have become a casualty of the 21st century. So I always, when I teach about documentation, how would you feel when your report's blown up on a big screen and you're sitting in the witness stand squirming because some lawyer is giving you a virtual colonoscopy about it? Is there compliance with not only the agency guidelines, so you have your EMS guidelines, but also EMS standards of care? We're staying within the standards of what you're allowed to do, what you should be doing, et cetera. And is there any explanation for deviation? Virtually every medical director I know will back you if you have a good reason for what you did, if it wasn't exactly according to Hoyle, but you have to write it out and explain it in the report. Individual QA, so we start with a focus on the individual performance. Was the care inadequate or improper? And then was the report insufficient, which is pretty common. You have a couple line report when it should have been much longer and detailed more about what went on there. Was the destination or disposition of the patient appropriate? Was it an appropriate refusal? Did you go to the right facility if it was an alert or something that needed specialty care? And then is there a reason for inappropriate care or inaction? So one, there are honest mistakes. Sometimes someone just missed something. That's a call for discussion, maybe counseling. What went on? How can we make sure it doesn't? Is there an unclear understanding? So I not only rewrote two sets of guidelines for agencies, but I did the training on them. So did I not write them well enough? Were they not clear enough when I explained them? So that might be something. We've made edits along the way. We now all pretty much have living documents in a PDF form so we can update it, change it on the fly, and make sure something is clear. Excuse me. Was it a deliberate act? Was someone just lazy, undermotivated, etc.? Now that might be potential discipline. But overall, we shouldn't be looking at this as what'd you do wrong. It should be why is something not right? So are you meeting the agency standards? Manual vitals seem to elude people. The name of the game now is clip on a pulse ox, slap on an automatic BP cuff. When agencies require manual vitals and I see a blood pressure 123/71, you know they're full of garbage because we were always taught from day one of EMT class, round up to an even number. Same with a pulse. No one counts for a full minute. So what numbers did you multiply to get 73? Or did you just take it off the monitor? You get a good rate on the monitor from PA also. So initial respiratory rate, everyone's got their favorite number. It's usually 14, 16, or 18. But as I've just been teaching, if that rate was really 12 and now all of a sudden it's 20, well, 18 and 20 is no big deal, but 12 to 20, something's going on with your patient that you should have probably paid attention to. Lung sounds clear and equal. So it's funny, I'm in a run of training and I pointed out that believe it or not, you need a stethoscope to do lung sounds because often I've seen lungs or whatever. Then you read the patient was admitted to ICU with acute pulmonary edema. Were their lungs actually clear and equal? Probably not. Or if anything, you just did a quick set of ultrasounds through a few layers of clothing. Were 12 leads timely and repeated? And we get to the end, I'm going to have some good examples of that. And cardiac arrest care. So two things I look for in a cardiac arrest. Was the initial defibrillation delivered promptly within the first few minutes? And I always track patient contact time, recognizing sometimes in a condo, there might be a delay from arrival to patient contact, but certainly within the first few minutes of contact, defibrillation should have been done. And epinephrine, I set a fairly arbitrary 10-minute standard because that told me, especially in the facilities, some crews would throw someone on Lucas or Autopulse, take them out to the truck, and then begin care like magic happened outside in the truck. If they actually started and did it, and we know with epi, if it's going to do any good, the sooner the better, that 10 minutes was a very liberal standards. It really should be 5 minutes. So who does the QA? It's often an EMS captain or some sort of supervisor. And typically they don't do every call. They take a certain percentage and maybe the alerts, but it's what I like to call a part-time side job. It's not what they're focused on. They're busy going calls, doing other things. So one thing when you're doing this is an Ernest Hemingway quote, but mine's a lot simpler. Shinola doesn't smell bad. So if it smells bad, it's probably not someone who's writing a report that doesn't reflect. So a lot of the times with reports, when we get to NEMSIS data and others, reports often reflect what should have happened on a call, but not always what did. Everyone knows, well, this is what I'm supposed to do. I'll write it up that way. No one's looking over their shoulder unless we have body cameras. So that's an issue. Also, when you only review certain reports, you might miss critical deficiencies. So for instance, lift assists don't generate a report, but we know from data, and this is where widespread data comes in, that a high percentage of those really should have had a medical evaluation. There might have been a medical problem going on. Maybe there was some other issue, but if they just, okay, lift assist, I don't have to do a report. Let's get back to the station. Now we miss what might be potentially an opportunity to intervene in something. Also, a supervisor who's busy getting phone calls, getting dispatched to calls, is not going to have that time to sit and just concentrate on the reports. So positive QA, which often doesn't happen, instead of finding out what went wrong, let's find out what went right. And part two, let them know about it. A lot of agencies are certainly quick to call someone into the principal's office when things are not right. What about letting them know, good job on this. You went above and beyond, you did something extra, you caught something that most people may not do. So error reporting, voluntary reporting should not be punitive. So you made a mistake, and probably most of you know there's a case pending right now. A medic who inadvertently gave rocuronium instead of ketamine didn't own up to it. It finally turned up at the hospital, and the patient didn't eventually survive. So the ability to voluntarily report to find out, was this an inadvertent error? Was this actually a problem? So we need a just culture. We need a culture where people know that, okay, I screwed up. I need to tell someone about it to make sure it never happens again and other people don't do it. QI really, now we're talking about opportunities for improvement. Not only what are we doing now, how are we doing it, but how can we do it better? So QI focus, you may discover systemic issues. So when one person's doing one shift, that's okay, but what are we doing now? And what's going on agency-wide? So captain or whatever on shift one or A shift might know his shift, B shift might know, C shift might know. When you have a QI coordinator, you're able to look across shifts and say, you know what, this is an agency-wide problem. We really need to highlight this for training. Also, you have to be willing to follow your data. So you might think you're better than you are, but you really may not be, and your data may show that. Doesn't matter, like Tanner, if you give a presentation on data from whether it's one company, NEMSIS or whatever, that looks good, it doesn't matter. If you read my article, will it play in Peoria? Will the average play in Peoria? The average nationwide might not be your average. So you have to be willing to do that. So when you see systemic issues, that's what demands quality improvement. In other words, how can the agency do better than what we've been doing, because there are issues that we can improve upon. So the QA coordinator should start reviewing QA. Now we're looking at what's been done and maybe more than that, other common issues, what could and should be done better. And you really need someone who's dedicated to it, who's also experienced. So if it's a part-time side job, like I mentioned earlier, that's someone who has to do it probably as part of their job. If you have someone who really wants to do this, has really been around a while, knows what should be done and shouldn't be done, that's someone who's going to be into it, looking for issues. So QA in summary is how we're doing today, and QI is how can we do better tomorrow. Comparing outcomes. So this is the most important thing I think I harped on for years before I did it, is what was the admitting or discharge diagnosis to what was the patient treated for, and let the providers know. So there's an important opportunity for learning. Let's say it's a care mismatch. Someone treated for CHF. More critical in the days we gave Lasix for that. But if the patient wound up with pneumonia, it's a very different treatment for potential sepsis versus acute heart failure. Also, was there a missed alert? One thing that would always get my attention when I got my weekly report was there a trauma or stroke transfer? Did we not go to the right facility? Then I'd look at the report. Okay, was it something that was missed, or was it just something that hadn't developed at that time? Don't wait for automated care outcomes. I know I've spoken to Peter. There's some systems where they get the automatic feedback from the hospital, but not every hospital is willing to pay for that. What I did, I had two things. So I would have one hospital that was the main receiving hospital automatically on Monday, gave me a list of every patient, what we brought it in as, and what was the outcome of the patient. And then I would call through the list. It was an ankle injury and they wound up with an ankle sprain. No big deal. I didn't feed that back. But it was a patient who wound up respiratory. What was the outcome? A cardiac patient who had a STEMI, something. Then I would automatically send that back through the reporting system so they knew, because to me, that's the best way you learn. You learn by knowing this was what happened with this patient. So that's how you develop your clinical judgment, by knowing the outcomes of your patient. Training is often based on what have we not done for a while. At one agency, we need to do our quarterly training. We haven't done EKG in a while. Let's do that. Okay, but that might not be what you need. Some skills like advanced airway, which we talked about just last week, should be done on a regular basis. Something like a crike, a high acuity, low frequency type event, we need to do because we don't do it often enough. But QI can often identify those widespread issues that, hey, we need agency-wide training on EKG, on stroke recognition, whatever it might be, that we're not quite where we should be. So the QI coordinator, when I did it, I was also the EMS instructor. So I would actually develop my own training based on what I found, instead of just doing something because I did what I felt we needed to do and pass that along. So studies, we get these wide studies that we hear presentations on. It's often based on that average data from multiple systems or studies. So that's actually useful to identify a particular procedure or treatment, might be good or bad. What's going on in the industry? What are the trends? What are the standards? Are we not keeping up with the Joneses? But here's some examples. So cardiac arrest care since the 70s, since I started with it. So originally, and Dr. Pepe, I'm sure, and a few others will appreciate this, 2 amps of bicarb was the most important thing in cardiac arrest. Doesn't matter if shockable rhythm, not. And then a milligram of epi, and then we finally got to defibrillate. It was a miracle we saved anyone. So through data, we eventually knew the importance of early defibrillation. This is way before AEDs were even thought of. The potential harm of routinely giving bicarb to patients, because it was thought, well, they're acidotic, they must need bicarb. Yet 6 decades later, there's still no consensus of epinephrine. You hear in the presentations, every medical director has some different way, some different aspect of it. Do we give it here? Do we not give it there? So averages can be misleading even within a system. Excuse me. So big deal now, the lights and siren collaborative. So emergency response mode might be an insignificant factor in a rural area. If you're driving on 70-mile-an-hour highways, probably doesn't matter at all. Traffic is probably passing you if you're doing 70. On the other hand, though, you have a congested urban area, it might make a difference. Now, some agencies cover urban, suburban, and rural areas, especially countywide agencies. I work for one. There's obviously differences as far as traffic lights, traffic congestion. I always give the example, within a mile of my house, there are 2 traffic lights that can delay me by 4 to 5 minutes. So if you have to stop for 20 seconds to get through, or even better, if you have traffic preemption, now you're saved. Doesn't matter. People say, well, it's only 5% of the times. Well, if 5% of us are on the edge, neuron-wise, if we lose enough, I'm toast, especially at this age. So average CPAP, this was another service I had. They realized when we had fixed flow CPAP, fortunately now they're mostly variable, was 7.5 was the average. We know that some people require only 5, and some, especially CHF, require 10. So 7.5 is a little too much for some, a little less for others. So the average there was really not appropriate. Measles, this is a current thing. So the vaccine average is down to 93%. Oh my gosh, it should be 95%, but it really doesn't matter. If your community is 100%, it's not as much of a problem. Some others might be 87% or even lower. now you have more of the problem. So it doesn't really matter what the national average is. It matters what's going on in your backyard. So it's critical to analyze your own data because system differences might be demographics. Example of that, when I QI'd stroke, the community I did, the average age of stroke patients was 79. Obviously, outcomes will be different than a community with younger patients. Population health overall, we know we have some areas where impoverished areas, patients without access to certain health. Response, what sort of response you have and what sort of time is involved to getting someone there. What's the provider level of training? Are they more basic or are they more advanced? And the specialty hospitals. You know, we're blessed in this county or this whole region actually with comprehensive stroke centers within a very short travel distance. What happens in these areas we hear about where they have an hour or more to get to one? Now they have a different decision to make as far as what they're going to do or what they're going to be able to do on scene. Note here, just for positive disclaimer, none of this is real data. It's all been created, so someone doesn't get their panties in a knot about it. So all my data entry started with a spreadsheet. Now the spreadsheet, we started with demographics. If you picture this going down, every run had one full line. So every one of the spreadsheets had the same, so we can refer back to the basic patient demographics: age, date of birth, sex, race, which now we know there's disparities in care. The weight of that became important for dosing, et cetera. And which unit was it? Then I got into the times. So most agencies now can have this automatically populated. And note, some of these will have red. The red were machine generated. I had a program to say, okay, from patient contact to arrival or vice versa, how long was that? Total on scene time, transport time, and then arrival at the scene to the ED. So initial medical contact to ED, which became important with things like STEMI. We knew our daughter balloon time. We wanted to find out first medical contact to balloon time. With cardiac arrest, I added in these, so the defib time and contact to defib, which I mentioned earlier, and then that first epinephrine. How long after contact was it to the first epinephrine? Then I also added estimated downtime. Was it EMS or bystander witness? Was there CPR performed and or AED use? And what was the initial rhythm and EMS ROSC? I'll give you a note that I learned the hard way on all this is any piece of data, any data point you think you might need, do it sooner, especially if you have to do it manually, because going back over several months worth and culling it's a lot more tedious than just putting it all in here and easier to sort down. Then for the outcome, we have the famous AMC hospital. You'll see a lot. The patient went to the cath lab. That's the time of the device, which artery was blocked and what percentage, because I'd always get the cath lab reports. And then were they admitted, were they discharged neurologically intact, and the final disposition of the patient. With cardiac arrest, I would then take it and go down the initial arrest rhythm. And again, if you notice 10, 20, 30, nice even numbers, but basically what percentage were shockable, what percentage were PEA, and generally somewhere around half were systole, so we expect less of an outcome there. Was it witnessed? Did it get bystander CPR? So in this case, about a third were bystander witness, about half got bystander CPR. Was it EMS witnessed? And what were the total? About half of them were witnessed arrest. This I broke down into witnessed and shockable. So 6 versus 2 were, yes, they were shockable. Witnessed but not shockable was 3 out of 8. Unwitnessed and shockable were 4 out of 9. And unwitnessed not shockable were the rest. So about half in my imaginary world had bystander CPR, half the ones who got ROSC. And obviously we'd expect more ROSC than someone who had CPR going on. The bottom were EMS witnessed. And again, about half of those, 5 out of 10 were witnessed by EMS, the ones that got ROSC, and 3 of them were shockable, 2 were not. Then I put it into a big chart. So out of all the arrests, the number that got ROSC and the percentage, so 30 out of 60 out of all of them, and we used to break down primary, was it a probable cardiac event versus hypoxic event, got ROSC. Then 20 of those 30 were admitted. So 2 out of 3 ROSCs were admitted. 6 of them wound up neurologically intact discharge. So my criteria, the CPC 1 and 2, or as I always said to Peter, can they wipe their own butt when they get done? So neurologically intact is 20% of ROSC. So I took percentages as I went along. And then overall, if 6 out of 60 survived, it's about 10%, which is pretty much what we have. And then I broke down the survivors. I picked them again. I just picked random ages. How old, male or female? What was their initial rhythm? Was it witnessed? Yes, by bystander or EMS if it was. And did they get bystander CPR? This one I just threw into every class I do on BLS, ACLS, etc. It's the Resuscitation Academy in one slide. So the things I always highlight, one, turning on the monitor on patient contact so we know how long we've been working there. Beginning manual CPR, because a lot of places think, well, we'll get auto pulse or Lucas out right away. To minimize the interruptions, and then going to the other side, even though we use rise in CO2 as our surrogate for a pulse, that by pre-locating a femoral with CPR, we know as soon as we pause if it's there or it's gone. And pre-charging the defibrillator, which not everyone is still doing, but if you're ready to go at that 2-minute mark, you can minimize your pause. Okay, pause, squiggly line, shock, get back on the chest. For STEMI, I added in a few other things. So roughly from the onset to 911, so we could track, we need community-wide education. What time was the 12 lead done? So in this case, it was 5 minutes. That was generally the standard. We always say within 10, but within 5 is certainly better. What time was the alert issued? And did they get aspirin? When was that given? And on the bottom, the correct diagnosis was it in fact a STEMI? Did they go to the cath lab? The balloon time and door to balloon, and then, like I mentioned earlier, first medical contact to balloon, which artery was blocked, what percentage of it, and what was the outcome for the patient. Here's an interesting one. So if you look, V2 jumps right out at you. Lead 1 is kind of subtle. AVL is a little more. Most people would look at this and say, well, it's just one lead. There is some depression in lead 3 and AVF, but it wound up, it's 100% mid first diagonal. So when you look closely, you see 1 in AVL. So we know we have elevation there. So it's a lateral. And V2 is specifically pointing to that first diagonal. And then if you look at the reciprocal, lead 3, the depression, well, from QI, I realized and looked it up that that's what they call the South African flag pattern. So if you look at the green line, it points from 1 through AVL to lead 2, V2, and then lead 3 is the one that has the depression. So coincidentally, every time you do this, it somehow points to the nearest Tesla dealership. So this is probably the most interesting thing I'm going to say that should get attention. So this was a male in his 50s who had chest pain. They did a 12 lead very quickly in the house. And if you notice, there's no acute changes, nothing remarkable. Okay, maybe a slightly elevated rate, but nothing that's a big deal. Once they got in the truck, and this is 10 minutes apart, they had virtually the same identical 12 lead. So now you're thinking, okay, it's probably not a STEMI, life's good. But 5 minutes later, as they got to the hospital, look what happened. I highlighted for effect. So notice this elevation that wasn't there 5 minutes before, hence emphasizing the importance on serial 12 leads. Now, one advantage I had, if you have LifeNet or RescueNet with Zoll, you're able to review the entire report and all the 12 leads, not just what was put in the report, and you could see things like this. So I made it my business to review every single 12 lead that came across my desk. Here's another one, male in his 40s, went for care, and he had a normal EKG. It had chest pain for several days. His vitals were normal. He appeared normal. Okay, let's take you up to the hospital. Now, as they got to the hospital, they did another 12 lead, and look what happened. This was within, again, less than 10 minutes of each other. So obviously, they're going to walk through the door. Hey, doc, this just happened. The guy wound up going to the cath lab, had a big old thrombus removed, and did well. But notice now from here, hold this thought. 5 minutes later in the ER, before they transferred, they did another 12 lead. It was gone. So if they didn't capture that second 12 lead, the patient would be waiting around a while to get some care because this wouldn't get anyone's attention. So think about that. That something we see might not be something that's seen later on in the hospital right away. So learning point also, there was a missed STEMI, and I wondered why, what happened here. So the crew believed, and it's been promoted, a certain monitor after after ST elevation would automatically print. The newer version of it just automatically notifies you STEMI detected, but it takes 2.5 minutes of continuous elevation. Think about the ones I showed you. Changes come and changes go. So to make sure, because I looked it up in the manual and I told Peter, and one of his chiefs said, no, I was wrong, but I actually took a simulator, hooked it up to that unit, and it does take 2.5 full minutes before it actually spit out STEMI. So you have to be aware of that when you have that. With stroke, so I timed onset to 911. It was known, okay, and there was some confusion with last known well versus symptom onset, which I'll talk about. And then the race score. So I tracked the race scores and then the outcomes. These I had to get manually, but what vessel was occluded, what was the door to needle time, and then the first medical contact, then our door to groin time and door to revascularization. The outcome, TICI-3 in this case, full flow, Rankin score of 1, and patient was discharged home. The 90-day modified Rankin was a bit elusive because often the patients were discharged to one facility, sent to another, and they often lost track of them after that. This one I didn't fill in every month, and again, I made up data. But if you look across, this is where I put my master stroke. So how many alerts did we have in a given month and a year? If you notice on the bottom, I compare 1 year to the other. What percentage of them were ischemic? What percentage were TIAs? What were hemorrhagic? And that was typically close to the average overall nationally. And then the others, the seizures, the migraines, the tumors, et cetera, because that often turned up in about a third. The ones that only got TPA, the ones that only got endovascular, and then the ones that got both. They got TPA or TNK, it would be now, and also went to the lab, was the ischemic stroke treated. And it was noted, well, I'll get to that in the end, door to needle time, first medical, so all the averages there. Notice the onset to 911, but then I took a 95% average, the top 95%, because I realized the ones that were sometime yesterday might not be exactly 24 hours or 18. It was skewing the data. And then the onset to 911 plus treatment, and it was consistent that the ones who called the fastest were the ones who were going to get treated and have better outcomes. So I took, and this I just plucked out for convenience, a couple of TIAs, a couple of acute infarcts, not an elbow, elbows, bleeds, and then others. And I correlated that to the race score. And you'll notice that in some cases, like the TIA, we expect a low number. With the strokes, both happen to be pluses. They had some sort of indication of a cortical sign. And the elbows, one was a 2, one was a 6 plus. So it didn't always correlate well. The bleeds generally had higher numbers than the others. Look at the UTI, that had a 6 plus. And again, this is old data plucked from many sources. So elbow to race, now I looked at it the other way. And for convenience, I just took race 2, 3, 4 up to 10 plus. So I correlated what were the numbers and what was the diagnosis of it. So some of them, like you saw, right M1 occlusion with only a 3 of a race score, probably hadn't gotten that bad yet. Maybe it was a quick one. But the one thing I noticed was a lot of pluses that turned out not to be elbow. So I wondered why, and I noticed there was a lot of aphasia that really wasn't. So that became a training point, which I do to date, differentiating dysarthria, because people were scoring up dysarthria as aphasia. And then the difference with aphasia being a cortical sign and receptive versus expressive, which are each 1 point on the race. So time of onset also, last known well, we know the symptom onset because you saw someone stroke out versus the wake up stroke. We know the last known well, but we don't know the onset time. So we talked to mom last night at 11 o'clock. We find her on the floor at 7 this morning. We really don't know if it was 12, 2, 4, et cetera, but we do know the last known well. With sepsis, I'd also track in what were the symptoms, what were the vitals that prompted it? Were they hypotensive, their temperature, end tidal number, and how much fluid was given in the field? We're getting more and more closer to that liter, at least. So which hospital, and then the lactate that they got, how much emergency department fluid did they get? When was it done? When were the cultures drawn and antibiotics given? What was their door to antibiotic time? And that helps track for us the hospital time, because just like with some other things, if they're not going to do it in a timely manner, either we're going to do it, which in this area, antibiotics are given pre-hospitally, or we're going to go someplace that will. For trauma, so I added in alert time, extrication, and air medical, both things that would delay the amount of time for some reason, where they upgraded in the ER. So we had a patient who came in not a stroke alert and had to be transferred or upgraded. And what was the outcome? They were admitted, in this case, TBI, et cetera. And now I added, because it wasn't a thing at the time, was whole blood indicated and was it administered? Something we need to look at to see indications and present data to our folks in charge. overdoses became a big thing when I was doing this. So was there an opioid involved, either from the hospital, I would get that, or someone who had respiratory depression, pinpoint pupils, and responded to Narcan, I would classify as opioid involved. So how much? So we took the average intramuscular, intranasal, the average that had it intravenously. Did they respond to Narcan? The cardiac arrests, which were almost certainly not going to survive, and the ones who were dead at the scene. So we knew that we can track those also. So now with overdose, I would take it month by month, and I would look at the totals, opioid related, all the things I talked about, and add that up. So if you notice towards the bottom there, I have the total for the year. Across the left side, I have the total for the year before. So we can track trends. If you notice quarter by quarter, we can see that all of a sudden, obviously, we have a rise in something going around, and we have a rise in overdoses. Totals of all the alerts. I did this monthly, quarterly, and annually just to know like where are the alerts, where do we have to focus. Also for new medic training. If a medic had never handled a sepsis call, where was it most likely to happen and when was it most likely to happen? So I did that by zone also. Let's say within your county, you have a city, you might have city number two, rural area, et cetera. Another would be outside of your normal response area. So how much of each? So this would be one, like I just mentioned, sepsis. I note that area two has the most of those. Okay, new guy, we're putting you there for a month. You're more likely going to get it, probably because there's a lot of adult facilities. Same with cardiac arrest and others. So I knew where it was happening. This is something, just stay current on what's going on. There's a big deal now with the H bombs. We've gone through the EPIC study and all, but I found my old BTLS slide from 2000, and look what it said. Prevent hypoxia, maintain good circulation, and a BP of 110 to 120, and hyperventilation was no longer recommended. So it's not like we found something wonderful. We just discovered what we should have been doing for the last 25 years. My final thought, I know 2 minutes over, but the only way to be the best is to realize you'll never be the best. So if you think you're the top-notch service, you're the best of the best, someone else is going to top you. You need to learn to do better in what you're doing and know that it's CQI because you can always be better than what you're doing today. And with that, thank you.
Thank you, Lou. Before I open it up for questions to everyone, I had two comments for you. A couple things that I wrote down while you were presenting. So first of all, when it comes to getting hospital data, so getting some of these data points about, for example, which of the STEMI patients we get in, what vessels occluded, the time to reperfusion, those cath lab reports, things like, which patients were LVOs, did they go for reperfusion? How would you recommend building relationships with your hospital systems to actually get this data? Because I know, for a lot of EMS systems that I'm familiar with, they just don't have those relationships. They wouldn't know where to start in getting that data.
You have to cultivate them. So you find out who's doing it. You meet with them, explain what you're doing and why. And I had people in each hospital I can call where they automatically did it. When it came to the ER, she got to a point where I'd automatically get a spreadsheet every week on Monday. Here's all the patients from the past week that had one of your units. Here's what happened, the outcome, discharge, admit. With stroke, STEMI, I had to manually do it, but I met people at EMS provider meetings and others. I got to know them. They got to know me and my charm and wit. And I was able to just pick up the phone. I knew when, like the end of Monday, I would find out. I didn't do them every day. That might be a week or so or 2 weeks just to give them a chance. And then I'd find out and do that manually, but then I'd feed that back to the crew. All the alerts I always went through at the time was safety pad. I'd send a message to each of the crews. Here's what your patient's outcome was. Here's what happened to them. Because again, I think that's the best learning in the world.
Yeah. Now, were the people in the hospital going into the patient's EHR, whether that's Epic or whatever else, or did you have access to that system as well, or were you getting it all secondarily from people who were collecting it in the hospital?
I was getting it secondarily. Now, Palm Beach County is an interesting thing. And I'll tell you an interesting thing I found. When we started using fentanyl years ago for cardiac issues, we had a patient who the doctor in the ER didn't like us using fentanyl. And he actually, the admitting diagnosis was cardiac something and fentanyl overdose. So that obviously got my attention. So I looked back and there was an appropriate amount, probably 50 mics of fentanyl. So Palm Beach County ordinance says they have to share the patient report with us. We went in and we got the report. and there was no overdose involved. It was a let's get the medical director involved in this and let's fix this before it gets out of hand. So some of it is that nowadays you might get more automatic. I know there's two-way communications with some of the systems. I didn't have that, and I know some of the PCRs still don't have that. So it's a matter of secondhand them giving me what they had.
Fantastic. Yeah, and another thing, so and I've been doing some work recently with continuous waveform data from CodeStat and Zoll's case review as well. And I think the point you made about having access to these files and being able to review serial ECGs and continuous waveform data, I really do think that that's tremendously important. If time and resource intensive, right? I know so we're looking at cases where transcutaneous pacing was performed, and so a lot of these are cardiac arrest cases, and we were seeing a lot of things like non-shockable rhythms that were being defibrillated, VF that was being missed for minutes and minutes prior to defibrillation, right? Like things that should be the subject of QI and QA. And so I think that cannot be overstated how important it is that if your system does not have a code stat license or doesn't have access to case review, I really think that is something that you should prioritize investing in for the purposes of QA, for the medical directors to be able to go back and look at these cases. That would be something that I would like to highlight. Um,
I reviewed probably 10,000 reports a year. And typical day, it might take me an hour. Reports for a simple BLS call might be 30 seconds. But then some reports would get my attention, and I'd go into the code stat and I'd look through the entire report. I'd look at all the 12 leads. And that's where those examples came from looking at everything in it.
right.
So, yes, I 100% agree with you on that.
Yeah. Anyone else? I don't see any hands raised. Feel free to shout out if you have any questions for Lou. All right. Well, if not,
Don't forget before you go, though, to put in the link for the Eagles.
oh, absolutely. I'll put that in. Yeah, so I just put the CME code in, and I'll put the Zoom link to join the Eagles webinar as well. All right. So it's become tradition to let the speaker have the last word. Any other words of wisdom before we let you go and enjoy the rest of your birthday for us?
Actually, I have the other webinar coming up in 2 hours, but for any of you who want, it's on capnography. So especially if you're not very familiar with all the different things we're learning about it, it'll be hopefully pretty good. The final word is just basically this is something that you really need to do. If you don't recognize it, if it's a side job for someone, then you're not doing it well enough to improve your agency. You have to have someone who's dedicated to it, wants to do it, has the experience to do it, and you will learn a lot of things from the world around you and your own world that can make you improve and be better tomorrow.
Yeah. Thank you again for that wonderful presentation. Did
Thank
you
you.
want to put a link to the capnography webinar in case people want to join?
I can do that if you give me a minute.
Sure.
And actually, I meant to tell you if you could put a link to the article on QAQI.
Sure.
You have that? It was from October, November or so. It's on EMS World because that kind of
Uh,
ties in.
is that the QAQI the same thing, right? That's the
Right, right.
title. Yep, I got it.
So there's capnography. Here it is. Copy. And there it is. That'll be at 2 o'clock today.
Are you going to be talking about VCO2? Gordon Miller? Put in the chat.
That's my thing
Fortunately,
right now. I love it.
I'm in a run of 25 days of training with the department, and I've got to beta test the capnography and fine tune that along the way. So it played well in not quite Peoria, but locally. So we'll see.
All right. Yeah, I'm able to see that link to your webinar in the chat. as well. So thank you all very much for joining.
Thank you, John. I'll stay for a few minutes just in case.
So, Lou, have you looked into the volumetric capnography much?
I have not specifically. I'm on the education end now, having done this for 53 and a half years. Not in the field thing, so I don't have specifics. You mean researching it or using it?
Using it, utilizing it. It's so
Oh,
I'm just
yeah.
starting. I just started utilizing it not too long ago, and you start comparing it to actual just your PET CO2 and end time. It tells such a different story, and that'd be a topic for another discussion we could have. But it's obviously we use it on the T1s, but I'll
Right.
definitely try to join your thing today, kind of watch it. But
One thing I highlight, not only there, but there's a companion article that came out Monday. It's also in GEMS that the number might not be 100% accurate to what's going on inside the body, but if you follow the trend of it,
right, and that's what I teach
my
everybody about end title. I'm
I
like,
have
hey, look at the labs
my
at the hospital.
favorite Right. I have my favorite title of an article coming out next month. It's called Take My Pulse, Please, but follow the trend. So if you have a patient, the end title is low. Okay, maybe it is, it's not, but they're not responsive. And now you pace them or you give them whole blood or whatever, and the number changes, but they become alert and they get a good radial pulse. They got better. It doesn't matter if we're 100% accurate, it matters they got better.
The big one I was tying it to was the actual anemia in blood versus numbers and looking at it. And I had a woman who is severely anemic. Her end tidal was 35, 40 the whole time. Her VCO2 was in the tank. And it was like, oh wow, there's what I'm looking for. So that's what I'm really using it for, is like blood administration, looking at end tidal versus volumetric, and all those kind of metrics. So we'll see where that goes.
Funny, because my last article was before this one was called Trees in the Forest. So it's you get all these numbers, you look at everything, it looks good, and you forget to look at your patient and the fact
Yep.
that your patient is
That's
dying,
yeah,
even
that's
though,
like it's crazy how bad it is with younger people. I'm like, touch your patient.
yeah, yeah, they forget that now, and they forget, take a pulse, look at respiration, get a manual blood pressure. Don't just read numbers. You want to just read numbers, so I'll offend someone here. That makes you a nurse, You guys in the field, probably because I come from the 70s before